So if we could have the overview slide. Thank you very much. So I'm going to just say a few words to set out the day, and then Richard will talk us through the ups and downs of the year, triumphs and achievements. Ned will talk us through the performance, and also Darren and Russell. Matthew, our medical director, will be here to talk about quality, and then Richard will look back on the experience of COVID-19 and look forward on our journey towards outstanding. Ned, our COO, will then come back to talk about the restoration and recovery of services that had to be slowed down during COVID, and then we will go to questions and answers, which is hosted by Jenna Davies, our Director of Governance. Finally, I will close with a few words. So that's the overview of today. So first of all, I would just like to start off by saying thank you to all staff and volunteers and everybody who came out of retirement to help us with the COVID effort, which was obviously huge. It was a huge challenge, and it was the sort of challenge that people had never anticipated having to face. So our appreciation for everybody involved in the efforts is absolutely huge. So thank you to everybody. I think it's also worth taking a moment to specially thank the volunteers for the tasks that they did, which included manning PPE stations at the hospital entrances, helping people find their way around the hospital, delivering stocks of PPE to wards, helping patients speak to their loved ones by video and audio, pharmacy runs, clinical support, photocopying, scanning, collating patient packs, and just generally supporting the office, even with helping bereaved relatives get hold of property from people that they had lost. I think it's also worth saying that a lot of our long-standing volunteers that have worked for many years supporting the hospital had to isolate, and so a lot of younger people volunteered their time. And so we're grateful for everybody who volunteered, both long-standing volunteers and the newer ones. Thank you for everything that you've done. It's also worth saying that a lot of local businesses and community organisations contributed support in other ways. So it was the Clap for Carers, which everybody in the NHS appreciated. But in addition to that, some practical contributions and donations that were very gratefully received. It's also important to acknowledge that for our staff, this has been a particularly taxing time. People have worked very long hours. They've been involved in very stressful situations. They've had to deal with really challenging circumstances. Sometimes they've had to spend time away from their families. And so the Trust has really been mindful of this and tried to put in various different types of support to help colleagues to relax and to recuperate in between the very difficult, challenging situations that they face. And the Haven Room was one particular example of this, which provided a safe space for people to take some time out and to relax, but also to get support and have a quiet, supportive word with therapists as necessary. It's also absolutely vital that we remember the colleagues that we have lost. It's very sad to say that we lost 2 members of staff to COVID, but also we lost numerous other members of staff during this time. So it's a very, very sad loss. We see ourselves very much as a family at Walsall, and so we're really, really sad to have to remember those colleagues that we've lost, but important to take a moment to just reflect upon that. One of the things that we've done as a board is establish a pledge, and this is to hold ourselves to account for how we support our colleagues and create an organisation that is properly respectful and values the work of our colleagues and creates an environment where colleagues can give of their best and really feel supported. And so this board pledge, which we monitor the progress through our people and organisational development committee, and see how well we're doing as an organisation. But it's really important to acknowledge the fact that we've developed this pledge, and it's really in response to the request of our staff, who have devised the trust values, which is how we work together to create the sort of environment that we want to see as a trust. And as a board, we are here to make sure that that is the environment that we create. So this is the pledge. We, the Trust Board, pledge to demonstrate through our actions that we listen and support people. We will ensure that the organisation treats people fairly, equally and inclusively, with a zero tolerance of bullying. We uphold and role model the trust values chosen by you. I cannot tell you how important that is, but as an organisation, this is something we are striving towards. We're not there yet, and some of the things that our executive colleagues will tell you about later will focus on the work that we're doing to take this forward. So I'm now going to hand over to Richard, who's going to give us an overview of the last year.
Thank you, Danielle. Now, clearly, today's annual general meeting has been deferred. You know, we're holding this towards the end of September. And of course, the subject matter is a review of the previous financial year, which ended at the end of March 2020. So there are elements of what we are going to go through that, in a fast-moving NHS environment at the moment, will feel somewhat out of date. But I think some of what myself and my colleagues will share are very much pointers towards what we are seeking to improve right now and seeking to improve on our journey to outstanding by 2022. So this slide is a lot of numbers, and on the face of it may not show very much at all. But there's a couple of things I'd like to draw out. Firstly, the population that we serve. There are something like, I think, 330 local authority areas in England, and Walsall as a borough is the 26th most deprived, economically deprived borough, and one of the most ethnically diverse as well. And I always remind new staff at induction days about that, and about the fact that indirectly or directly, that will impact hugely on the care that they need to provide and the support that we provide to the people delivering the care. And of course, as a result of the COVID experience on both the economy and society, that's going to hit Walsall as a borough even harder. We see the diversity and deprivation of our borough reflected in activity that we carry out. Significant increases, as you can see, year on year in both emergency department, A&E department attendances, emergency admissions and outpatient appointments. And all of these are running at increases that exceed the growth allocations in funding that health service commissioners receive and then pass on to NHS providers through their contracts. Can I have the next slide, please, Trish? And this is my overview of the year through, in particular, a patient experience lens and a staff experience lens. So if we could have the next slide, please. So patient experience, ultimately our customers, the receivers of our service, are our patients, our service users and their carers. And we measure, one of the key measures of patient experience is the Trust's friends and family test. Would we recommend, or would those patients or family members recommend our organisation and the care they received to others? And this is the 2019-20 results. And of course, quarter by quarter, it's very static, but it actually demonstrates some key subtleties which do need teasing out. Firstly, the continued excellence of our community services in the eyes of those receiving the service and receiving the care. And secondly, the fact that obviously by virtue of historically struggling with the emergency access 4-hour standard, and because we provide A&E department care in such a poor physical environment, the emergency department patient experience scores are relatively low. Now, of course, going forward, we have seen improvements in our emergency access standard performance, and we are also seeking to radically improve the environment in which we deliver that care through the new emergency department build, which will be open in the summer of 2022. Could I have the next slide, please, Trish? Now, we also measure staff experience. So we have 4,350 staff in our organisation, and it is absolutely vital that we measure and seek to continually improve their experience as employees of our trust, because if our staff feel supported and professionally developed, they are likely to deliver better care. The 2019 staff survey results were, there is no hiding it, disappointing and of great concern to us. We overall saw a decline in 10 of the 11 themes in the survey compared to the 2018 survey. And that is despite a significant amount of focus and effort on staff engagement and the use of various staff engagement techniques and approaches to help those staff to improve the service they deliver and the experience they have as colleagues. Going forward, we have a overt and very, very intensive staff health and well-being and local leadership development focus, which has been brought into very sharp relief by virtue of the COVID-19 experience. And we do want the 2020 staff opinion survey results to reflect that effort, but of course we will determine whether we have succeeded in that regard at next year's AGM. Could I have the next slide, please? Thanks, Trish. So people will quite possibly be aware of this thing called Walsall Together. What is Walsall Together? Well, Walsall Together is an integrated care partnership, and an integrated care partnership is, in essence, a partnership of equals, statutory organisations such as Black Country Partnership Trust, ourselves and the local authority, as well as equals from the non-statutory and voluntary sectors such as Walsall Housing Group and One Walsall. And the partnership is intended to plan for and then deliver more integrated offer to residents of Walsall, such that we can achieve what in NHS plan terms is called the triple aim: improving health outcomes for the population, improving the quality of care that we actually provide when care is required, and then ultimately to seek to provide longer term financial sustainability in the system through the better management of chronic disease or the avoidance of it. Going forward, it is our intention to focus much more intently on health inequality reduction in a borough that, as I've already described, has significant health inequalities and latent deprivation. Walsall Healthcare NHS Trust is the lead provider for the integrated care partnership that is Walsall Together, and we are accountable to our commissioners, the council and the CCG for improving the integration of service delivery. Going forward, we will seek to deepen that integration based on mutual trust and shared goals and objectives. Next slide, please, Trish. A few good news stories that we wish to tease out from 2019-20, and of course Ned Hobbs and Matthew Lewis will very much go through some detail with regard to performance and quality issues. But one of the key highlights, of course, was the opening of our new neonatal unit. It is one of the best pieces of NHS estate that I have ever seen. And I said that last year when I was talking about our new integrated critical care unit, but the neonatal unit more than matches it for quality of environment and the care that we now provide within it. 2019-20 also saw the start point of developing the electronic patient record for Walsall. We were very much in the foothills of using information technology to help deliver improved healthcare in Walsall. And I'm pleased to announce that the first key stage of rolling out our electronic patient record, which was turning on our patient administration system, took place 2 weekends ago and has thus far, in relative terms, gone without any major hitches. We also developed our quality improvement approaches as an organisation in 2019 and 2020 through the Quality Improvement Academy, which is there to sponsor the techniques, the evidence-based techniques for clinical staff to develop and improve the quality of their service, and then of course to recognise best practice in what our staff do and disseminate that throughout the trust. And one example of that, but there are many, was the bedside mobility assessment tool, which is a critical one for me because it is absolutely directly aimed at reducing the risk of hospital-acquired functional decline in longer stay inpatients through fundamentally improving their mobility from the very minute that such a patient is admitted to one of our inpatient beds. Can we have the next slide, please? Thank you. And of course, the organisation doesn't just focus on the delivery of care using NHS Exchequer funds, but it also seeks to raise charitably raised money to supplement what the NHS can provide in Walsall. And we continue to, and have continued to throughout 2019-20, develop a whole range of fundraising activities which support the patient care that we provide. And as Danielle has already highlighted in her introductory remarks, the right-hand side of this slide demonstrates the sheer range of volunteering support that we receive as an organisation in both our community and acute hospital services. And although the COVID experience has significantly changed the number of volunteers and the profile of those volunteers for obvious reasons, nonetheless, I would like to put on record our profound thanks for the support that over 300 people, some of whom have provided over 35 years service to the Trust. I'd like to put on record my thanks for their support during the last financial year. So I think that concludes my introductory remarks, and I'm now going to hand over to Russell Caldicott, Ned Hobbs and Darren Fradgley, who will go through the key areas of NHS constitutional standard performance and also our financial performance. Gentlemen.
Thank you, Richard, and thank you, Chair, as well. So good afternoon, everyone. My name is Ned Hobbs, Chief Operating Officer here at the Trust, and I had the pleasure of joining the organisation during the 2019-20 financial year. So I'm just going to take colleagues through a summary of particularly the main 4 constitutional standards that we report and are measured against. The first one being the 4-hour emergency access standard. And I think the story of this is a really important one for this organisation over the last financial year. Colleagues will see that in April 2019, unfortunately, the organisation was 103rd out of 118 at that point reporting trusts in the country. So right towards the bottom of waiting time performance relative to other hospitals. And throughout the financial year, the relative performance here at Walsall Healthcare showed sustained and continued incremental improvement. And this is a testament to people working all the way along the emergency care pathway, to our colleagues in community services and as part of the Walsall Together partnership that Darren will expand on in due course, to colleagues within the emergency department itself, who were dealing with record numbers of attendances, as Richard's already mentioned, and to colleagues throughout our in-hospital services, on our emergency assessment units, inpatient wards, and all services that support them. This was a huge team effort. It won't escape people's eyes that March 20 saw a sharp decline in our national ranking, and that was directly associated with both the extent to which COVID-19 hit the Black Country and how early on in the pandemic it hit the Black Country, which did see our waiting times temporarily suffer in March and April in particular. But in next year's AGM, we'll talk through how those have subsequently recovered. Next slide, please, Trish. Oh, I think we may have jumped one. Yeah, thank you. For routine elective care, we're measured against the standard of patients receiving their treatment within 18 weeks of being referred by their GP. Our actual performance for this saw a slight decline during the course of the year, but our relative performance to other trusts, which is the right-hand chart, remained very, very stable, typically between 30th and 40th best in the country. And that's a credit to our colleagues in outpatients, operating theatres and all our other elective services. Of course, routine elective services are the services that were hit most by the impact of COVID-19. And we have, like all hospitals in the country, experienced longer waiting times for patients since the pandemic started. And of course, next year's AGM will reflect on that, and my restoration and recovery section a little bit later on will expand on that a bit. Thanks, Trish. For cancer performance, we have a range of waiting time standards, but probably the most important is the time from referral to definitive treatment, and that's the 62-day standard. And we performed solidly throughout the last financial year, both in actual terms and in relative terms, in terms of our national rank. I think this is, of the four constitutional standards, the one where we have probably greatest desire to see material improvements in waiting times for patients with both suspected and then confirmed cancer. We've got a new leadership team now in our surgical division that lead our cancer services, and I'm very much looking forward to supporting them in the year ahead to reduce these waiting times for our patients. And finally, but certainly not least, our diagnostic services have done a phenomenal job during 2019-20. When I joined the trust, our national rank for waiting times for diagnostic services was 84th in the country, and I was quite significantly concerned about how long patients were waiting for tests like CT scans, endoscopies, and other diagnostic tests. And you can see, particularly in the chart on the right, how strongly our teams have performed through the rest of the financial year, including spending a number of months in the top 10 for diagnostic waiting times in the whole country. So a big thank you from me to colleagues that have made that happen. Our challenge in 2021 is of course sustaining that, but we've got a good platform to build upon. I'll just hand over to Darren now.
So, afternoon all. My name is Darren Fragsley. I'm the Director of Integration and the Deputy Chief Exec here at the Trust. And I also have the pleasure of leading the Walsall Together partnership on behalf of all partners. So just going to take a few minutes to talk about the progression in the integrated work that we've done over the past 12 months, notwithstanding the delay in the AGM. There's a little bit of jargon on this slide, so I will talk us through that jargon as well, and apologies for the three-letter and acronyms. So our place-based teams are, as I talk to each year, are there largely to connect with the local communities that they serve and address the inequalities and the deprivation that we see within different parts of the borough. And this year, more than any other year, we've certainly been making headroads into that. So you can see that we've got a mix of professional and voluntary sector staff that now support the 280,000 people that are in Walsall and the surrounding communities as well, in a way in which we can start to directly address those inequalities. And those inequalities are different dependent upon the areas of which we serve. So in the west of the borough, we see high levels of respiratory illness and social care support that's required in patients' homes. In the east of the borough, we see lots of complex, multiple conditions that require varying levels of support within patients' homes. In the north of the borough, we see a lot of the conditions that are due to some of the deprivation we see within the area, such as obesity and some of our safeguarding concerns. And then in the south, we absolutely see some challenges about the different cultures and the different cultural changes that we have. So quite a big task to understand local communities and respond to those in a meaningful way that they feel supported. Major step forward this year and in the last 12 months, certainly, on getting bases in each of the 4 points of the compass. So Darlaston, Pinfold up in Bloxwich, and Blakenall that now serves the east side of the patch, and then Eldon that covers the south. And going back probably 2 or 3 years, we've seen that as a significant step forward in terms of co-location of those teams. We've now got a formal agreement in place with adult social care, so the partnership is now truly integrated between health and care. And in realistic terms, this means that the two parts of the kind of statutory team now work together as if they're one unit, all reporting into the Walsall Together structure. And we're one of only about 5 areas within the country that's achieved this. The single electronic referral seems quite minor in most terms, but in reality it means that instead of referring to healthcare support or social care support or voluntary sector or mental health, we now have one route to refer into these teams, and the teams can then do a diagnostic of the patient's needs and the outcomes required and respond to those. So a major step forward with kind of minimal sort of impact on users of our services. Of course, with all of this sort of change, we absolutely need to redesign the way in which our teams think, and we also need to redesign the way in which our teams behave, so they behave as a cohesive unit. And one of the pieces of work that's currently going on is something called strengths-based practice. What this means is that we actually look at patients, their families and their carers' needs and understand how we reinforce the strengths and how we provide additional support, rather than a typical prescription of we'll just tell you what we're going to give you. So a major step forward in the way in which we think as a partnership. Specialisation within the community is definitely an area that we are lifting our focus on now, and when I described the different levels of inequalities within the borough, we're matching that with specialised services. So no longer will you need to come to the manor site for respiratory specialist advice, but we can provide that locally within your own community. And then the final one, which is the primary care-led multidisciplinary teams, brings all of those specialities together in the 7 places within Walsall, so around the different villages that are within Walsall, and make sure that we've got the best coordinated specialist support being led by primary care. Next slide, please, Trish. Thank you. So again, another success story, but significant benefits for patients. And the graph at the bottom shows the reduction in the delays and reduction in the length of stay that we see for patients that are in the manor site that require complex discharge support through our intermediate care services. And you can see at its height, it was well north of 10 days, in extremis at 12 days. And we've now consistently got that between 48 and 72 hours. The plan now is to bring that down even lower and maintain that through more proactive discharge support. Obviously, from a patient journey perspective, this is a significant improvement, and obviously much better in terms of your flow through the hospital as well. And then finally, the front door, the rapid response element of community services has been both our rapid response team that we talk about each year. So this is the team that aims to be with you in crisis within 2 hours. But we very early learnt in the COVID pandemic that we needed a coordination element to this as well. So on the top right-hand slide, you can see the number of calls per month that are coming into our new care coordination service. This service links seamlessly in with both the GPs, NHS 111, 999 and other partners as well, where a single phone call will link you to all of the services, and then the care coordination service will link the patients and their families to the right service first time, rather than individuals bouncing around the system. The bottom chart shows that we consistently avoid admissions or referrals for admission into hospital beds of well over 80% and often above 90%. So a very credible service with positive outcomes for patients and carers that access that service. Thanks very much. And I think I'm handing over to Russell.
Hi, thank you all. So I'm Russell Caldecott, Director of Finance and Performance. I'll take you through the financial statements for the 2019-20 financial year, and also just touch on 2020-21 as we are now 6 months through that process. So the first thing to say, financially viable going concern. All of our accounts and financial statements are produced on the basis we are a going concern. That means we have future positive cash flows for in excess of 12 months from date of the accounts, and our auditors support that going concern status. Every year we have to have an external audit attend. It's an external firm. They come in and check our accounts to make sure we've correctly stated all of our position, and we receive what's called an unqualified audit opinion with no adjustments from our draft submissions to our final account submission. So essentially a clean bill of health, so that our statements do reflect what has happened in the year from a financial perspective. So what do they actually say? Well, we've actually outturned with a small surplus in the year, and that does exclude impairments. Impairments are non-cash items, so they're excluded from assessment of performance from an NHS provider. And as such, therefore, we've hit a surplus for the financial year, which means we've hit our control target, which is the target essentially the centre give us to hit from a financial perspective. We'll touch on the 2021 operational planning. Clearly, that was suspended following the outbreak of COVID-19. The plan we were written to actually through the centre, and the plan assumes we deliver a break-even performance with an opportunity for a top-up. And we'll talk a little bit more about that as we go through the presentation. And of course, 2021, there is an assumption and a reality actually as we speak to you today that attainment of that break even does require receipt of significant additional resources. So just as a headline, summary financial performance. So this is for the 2019-20 financial year. Clearly our income around £294 million. And we managed to spend every penny of that in provision of healthcare. You can see in there we actually do have an interest model, so we do pay interest back, and that's essentially to the owner of our building and also for historic debts that the trust has accumulated deficits in previous years. So a surplus is not a given, so it's a good achievement. The impairments listed just below the surplus for the year. The impairment was, as Richard alluded to earlier, on taking the opening of our neonatal intensive care unit, and there is a slight fall in value that's taken to the balance sheet. It's very common practice. There's no cash loss until you actually sell the item, and clearly we're not planning on selling our new neonatal unit. So essentially we report a surplus based on our break-even duty for the year. Move the next one, Trish. Thank you. So how did we get our income? That's a good question. I think I'll address your eyes to the the pie chart, which shows 84% of our income is essentially generated through trading with NHS organisations, so effectively delivering patient care. And the bullet points to the other side sort of allude to that. Department of Health and NHS bodies, 250 million roughly of our 300 million turnover. And predominantly that's with Walsall Clinical Commissioning Group as well, so it's provision of services to local residents. We do get education and training research income, mainly from Health Education England. That's to support the training models within the junior doctors and other staffing groups. We've got local authority income, predominantly sexual health services, health visiting services. They're directly commissioned now by Walsall MBC, and effectively, therefore, they're a commissioner of services from us, a direct commissioner now. Non-patient services, clearly those are items that are outside of care delivery. A good example is we provide a centralised provision of service for information technology to the primary care services, and we recharge out for those costs. The central tariff funding is resource we've received from the centre to support our attainment to deliver a break-even performance for delivering what they asked us to do in terms of financial trajectories. And that clearly supported us getting to that break-even model. And then we've got other income, which includes, there's a notation there, but trading income and injury cost recovery schemes, so essentially ambulance remitting funds back through insurance companies to the NHS, and also the trading income with car parking, catering income. We offer residencies at a premium as well, so that's good examples of other income. You can move on, Trish. Excellent. So then we've got a similar presentation really in terms of our expenditure. So where does our money go? As you can see, predominantly in pay, 66% of our costs are pay. Over 100 million of that is directly with midwives, nurses, doctors. So it's substantial sums of resource into pay. Supplies and services are, as you would expect, but predominantly drugs, actually, drugs and dressings. We do have the general service as well, so patient meals, they sit within the 3.4 million, as well as laundry, linen costs. We have to look after our premises, of course. That's 16 million pounds of what we spend each year. Rent, rates, taxation, council tax. So we have all the normal bills, as well as the estate's hard FM maintenance. That all goes in there as well to keep the estate as it needs to be. We have a depreciation charge we have to levy. We don't pay anyone for depreciation because we've already bought the items. This is a charge back into the I&E based on how we have used our assets. So how much have we used our assets and therefore depleted their value in delivering healthcare, and that's a respective charge for that into the I&E position. We pay an NHS premium on clinical negligence for claims. We have establishment expenses, so telephones, postage, other staff related. Oh, it's come back, great. We've got services from other healthcare bodies. Predominantly that is the recent transfer of services and centralisation of the pathology service. That is the charge predominantly that we are levied, about £13 million plus per year to support pathology services being operated through another organisation on our behalf now. And then we've got other expenditure, so legals, transport, fines. The one that's not there that is also a bigger cost within that is our security provision of service. And I think it's just worth noting that we don't determine the cost classifications in the groups. So these are put together by Central Department of Health and NHSIE, so that when they add all the accounts up, all the costs sit in similar cost classifications, so they can do whole of government accounts. So that's why we sit a level of expenditure within other, rather than moving it into other categories that might give it more visibility. So we don't just spend revenue, we also spend capital, £11.6 million in the 2019-20 financial year. Clearly, which is alluded back to the neonatal unit, we also had the obstetric theatre that opened within the maternity area. Those two occurred during the year. We've incurred costs in development of our accident and emergency unit, so moving towards the new build for the emergency department, of course. There's examples under equipment of items we've purchased, mammography, the CT scanner, and of course ultrasound machines. And then, as we've already alluded to earlier as well, within the IM&T elements, so we've actually moved to a new electronic patient record, and predominantly most of the expenditure in IT under that £4.3 million resided within that portfolio. So we'll do a quick look towards 2021. What we've shown here is roughly a straight line forecast for our income and expenditure based on the initial months of the calendar year. You can see that takes us up to 312 million as a full year spend against the 294 million pounds we were talking about earlier. Clearly, this will not be where we end up. So we'll have step costs around winter, step costs on restoration and recovery, which will build that cost base up. So our initial thoughts and initial workings show that cost will be higher when we get to the close of the financial year. So we will have spent substantially more resource than what we've committed and spent during the previous financial year of 1920. However, at this time, we're not sure what that income allocation. We've received an income allocation through our sustainability and transformation partnership, which is effectively this area's healthcare provision, and we need to work through what that means for each organisation in terms of their income flows. So we're working on that as we speak. So the income is still a little uncertain, and going further forward than that is perhaps even more uncertain at this stage, in that we're looking at how that architecture and payment by results and block contracts that we've moved into this year perhaps embed as we go into 21-22. Capital-wise, capital plan for 2021, normally a fairly static. Once you start the year with your capital plan, it remains fairly static. What's happened this current year is we've received further allocations as the years progress, mainly as a consequence of COVID-19 and ensuring that we have appropriate facilities in place as we head towards the winter period. I'd like to pause and just run through a few quick headlines though, because it's really important. The Accident and Emergency Department, £5 million just over planned expenditure this year. We have received outline business case approval. We are in conversation with full business case, and we are in conversation on starting to build our new emergency department, which is really exciting for us. We've also, moving down that list, there's two key pieces of additional allocation being made. So 3.8 million for critical infrastructure works. We're using that to support our theatre air handling units in real need of replacement. So that's a real welcome allocation that's come down from the centre fairly recently. And urgent and emergency care, £4.1 million. And within the £4.1 million, we're looking at essentially waiting areas, rapid ambulance handover area, and investment into the frail and elderly assessment area, all to create capacity. The urgent and emergency care spend of the 4.1 is not about the new ED. This is about making sure we've got the appropriate capacity for over the winter period. Within equipment, you can see we've had a further 1.2 million above what we would normally plan for on equipment. A lot of that has gone to ventilators for obvious reasons around COVID. So we've been able to get some additional equipment and replace some equipment through that additional capital equipment route. And you can see down below in IM&T, we've committed resources for electronic patient record, which we've very recently gone live with, which again is proving a success. I'll touch wood, following on from Richard's earlier sounding on that one. And of course, we've been able to spend resource through COVID to support staff home working and move more into a digital environment. So using Teams, as we are doing today, of course. Okay, Trish, if you want to move forward. And then finally, really, this is just to conclude our slide. As Richard's already alluded to, we are resourced to offer that basic care provision through an NHS offering, and the charitable funds are a key component of us being able to go that little bit further. And we get donations from varying sources. And really, this is £250,000 we've been able to spend on things that are above the normal, above basic, things that we wouldn't normally expect to be able to provide. And there's some examples of what we've spent that resource on underneath, but there's a lot of the smaller stuff that really does lift the morale of the teams and the staff. So it's a massive component, even though it feels 250,000 on our 300 million previously, it feels like a small amount of resource, but it makes a massive difference. And so we just wanted to offer our sincere thanks actually at our AGM, as we do each year, to everyone who's supported us during that year. And clearly that's patients, relatives, volunteers, the staff themselves, and external funders, the like of which such as League of Friends and others. We're massively indebted to them to helping us deliver the patient experience that people using our services need. And now I'm handing over to Matthew.
Thank you, Russell, and good afternoon. I'm Matthew Lewis. I'm the Medical Director at Walsall Healthcare, and one of the areas of interest and concern to me is quality and safety. And the Trust has a very clearly stated ambition to be rated outstanding by the CQC in 2022, and quality is one of the key elements of that. And so our quality and safety approach in this Trust straddles acute and community services. It includes corporate services, divisions and care groups. And I'm very proud to say that it is multi-professional as well. So we engage with doctors, nurses, therapists, pharmacists, management teams in different areas. Last year we had a focus on a number of areas in 1920, including falls, pressure ulcers, nutritional assessments. We were keen to extend the working models of staff in many groups, including physiotherapists, pharmacists and nurses. We were keen to learn from the experiences of patients and our experiences of managing patients who died within the Trust by developing the medical examiner function, which is a national programme to improve the accuracy of death certificates, but also to support medical teams during these difficult times, and perhaps most importantly of all, to support relatives and to give them information and support and direct them to relevant services. We've got a strong focus on sepsis and managing sepsis effectively by giving oxygen, by checking blood cultures, giving antibiotics intravenously, giving fluids intravenously, and checking markers such as urine output and blood markers of sepsis, such as lactate levels. And importantly, we've got a focus on recognising what it is like to be a patient within the Trust and making sure that we improve the experience of patients who are being discharged from the hospital and improve communication, generally speaking, through our values-based customer care programme. Next year, we've got an ambitious improvement programme, which includes elements of quality and safety. We will have 4 programmes running together, looking at the CQC responses. So the Care Quality Commission have previously indicated areas where we need to focus our attention, and we will do so. Pathway to Excellence programme, Care Excellence programme, and harm-free care. We will continue to focus on sepsis, falls, ulcers, and nutritional assessments. We will add care of the mouth and hydration. We will look at medication errors, continence, VTE, so the formation of clots in the legs that can sometimes be significant causes of ill health or even worse. Making sure our cancer pathways are quick, but also making sure that they're thorough and that we carry out the right assessments and communicate effectively with patients. And lastly, making sure that we have a key focus on the priorities that are expressed by patients, by listening to what patients say they want and making sure that our services are responsive to those. So those are the elements that will be key parts of our quality improvement programme for the next year. Thank you. I'll hand back to Richard at this point.
Thank you, Matthew. I'm just going to provide a few very brief reflections on our COVID-19 experience and the impact that it's had. Of course, we are reviewing the year 1920 in today's annual general meeting. And we were only really in the foothills of the first wave of COVID-19 in the United Kingdom during the month of March. However, we must acknowledge the profound effect on society, public services, families, individuals, and the way we as a healthcare organisation deliver our care. We've got to acknowledge that profound effect that COVID-19 has had on us all. The following slides are largely a numerical depiction of COVID, but they don't tell the full story of the emotional or physical toll taken on our borough and our staff in Walsall Healthcare Trust, because, as colleagues have already said, the Black Country and West Birmingham system was very much after London in the eye of the storm of the first wave of COVID. This slide depicts on the right the number of Manor Hospital deaths from COVID that we have experienced thus far. And on the left-hand side of the slide, the number of discharges from hospital of patients who were admitted with suspected or actual COVID and diagnosed with COVID and then discharged with it, having been successfully treated and rehabilitated. Next slide, please, Trish. Thank you. This slide depicts inpatient admissions related to COVID from the middle of March on the far left of the screen through to the middle of September on the far right. And you will see the alarming and extremely difficult peak that we experienced during the beginning to the middle of April and through into May. And that resulted at one point in over 200 inpatients with COVID at the Manor Hospital, and at one point well over 30 critical care residents with COVID as well. You can see on the right-hand side of the slide how we are, as we speak, already starting to see a slow but inexorable rise in hospital admissions related to suspected or actual COVID, which is reflective, of course, of an increase in COVID incidence in the Black Country as a whole. Next slide, please. Clearly, one of the key and most emotive issues throughout the COVID period was the matter of personal protective equipment for staff, to protect obviously our staff, our volunteers, and ultimately to protect our visitors and our patients. We followed national guidance as an organisation throughout the COVID period and continue to do so. And of course, that national guidance has since changed, and we are now seeing all of our staff and our visitors having to wear a face covering. We were very keen to ensure that we were transparent with all of our colleagues, and we shared with them every single day during the peak of the first wave. We shared with them our stock levels for all the different elements of personal protective equipment, so we could be honest about where we had shortages and what we were doing about it. And I would like to put on record my thanks to colleagues in our distribution service who worked 24 hours a day and put in a huge amount of discretionary effort to keep our wards, departments and services supplied with the correct personal protective equipment. And of course, COVID now means that we have been able to put in place a series of radical changes to the way we provide our care that are now consistent with national and our own expectations and keep our staff and our patients safe. And I think the next few slides will focus on the improvement programme, which Matthew Lewis has already alluded to. But just before I jump into that, I just want to, as Danielle has already done, pay tribute to our two colleagues who tragically died in our own critical care unit, having been diagnosed with COVID-19. And I would like to put on record my thanks to all of our staff for their sense of duty, their camaraderie, their teamwork and their professionalism. We will be very much calling upon that effort as we tackle the forthcoming winter and an almost inevitable second wave and second peak in COVID-related acute illness. So our improvement programme is essentially designed to deliver our strategic objectives. And by delivering our strategic objectives in full, we are confident that we can achieve our ambition as an organisation, which is to have outstanding rated services, which of course is what the people of this borough have every right to expect. We have divided our improvement programme architecture and structure into our strategic objectives: safe, high quality care, because of course we're a healthcare organisation. Our job is to do that, to deliver care at home wherever we can, as often as we can, to address health inequalities in the borough, as I've already outlined, to work with partners, because we are not an island, both within the borough of Walsall, but critically across the whole Black Country. We need to work with other organisations to ensure that what we do and what we deliver is worth more than just the sum of the individual parts. We must value our colleagues, because our colleagues provide the care, and if we do not value our colleagues, their well-being, their engagement and their professional development, then we cannot deliver good care. And we must make effective use of our resources as well, because we are spending public money. All of that needs to be underpinned by strong governance and good leadership. So that is the structure of our improvement programme. And here's just a little more detail about some of the things that each element of the programme will be tackling. Of course, from a safe, high quality care perspective, it is critical that we get the fundamentals of care right for all of our patients, be they community or acute. From a care at home perspective, the COVID experience has radically changed already the way we deliver traditional outpatient care, and we aim to be doing a significant portion of that on a virtual or telephone basis going forward. From a partnership perspective, there's a list here of things that we are already doing with other trusts in the Black Country, including a conjoined dermatology service with colleagues in Wolverhampton, collaboration on an ENT surgery, on nursing bank, and on the clinical fellowship programme for medical trainees as well. From a valuing colleagues perspective, we have to make Walsall the best place to work, and one of the things that we need to do to achieve that is to tackle some of the long-standing issues that we've had culturally in the organisation, whether it be on a lack of inclusivity or an inconsistent way in which colleagues are treated and led. From a use of resources perspective, one of the key things we need to tackle is to assure ourselves that we are doing everything we can to deliver operational productivity best practice, so that we are making the most efficient use of public funds, for example, but not exclusively, through the productivity in our operating theatres, in our outpatient services, or in the use of our very, very expensive hospital and community health centre estate. And then finally, from a well-led perspective, everything that I've described in the other elements of the programme has to be underpinned by good governance, seeking assurance and evidence that we are making progress on everything that we want to do, by planning effectively and implementing those plans, and by putting in place the right balance between holding people to account for delivering those plans and supporting them with the resources and development that they need to deliver them. So I'm now going to hand over to Ned, who in particular is going to focus now on the future in a living with COVID world and how we are restoring and recovering services that were partially or wholly closed following the first wave of COVID. Ned.
Thank you, Richard. And as Richard said, clearly this element of the presentation is perhaps less about the 2019-20 financial year and more about both the present and the future for us as an organisation. During the first COVID peak, our planned care services, be they outpatient services, diagnostic services, or things like elective surgical services, were affected by the need to redeploy staff from those services into our emergency and critical care services to manage the number of patients presenting with COVID-19. And we're also affected by our requirement to promote and maximise social distancing in the community as well. The consequence of that is that, as set out in Sir Simon Stevens and Amanda Pritchard's Phase 3 COVID-19 letter, we are now, as a nation, needing to return our elective services back to as near normal or pre-COVID levels as we possibly can. And that's no small challenge, particularly when doing that in the context of preparation for winter, in the context of preparation for a COVID resurgence, and in doing so in ways that in particular support our staff and take action on health inequalities amongst the community that we serve. So if I could just turn to the next slide, please, Trish. In our approach to this as an organisation, we have agreed and indeed re-endorsed at board level how we will prioritise the resources at our disposal through this restoration and recovery period. Firstly, as we did during the first surge of COVID, we will always ensure that our urgent and emergency care services in both hospital and the community, and our critical care services in the hospital, are protected as our #1 priority. We believe those are the patients who are both sickest and have most urgent time critical needs presenting along an emergency pathway, and must always be our first priority. Closely following that group is our patients who have got planned care or elective care needs, but that those needs are urgent. And for example, these are patients who may have suspected or confirmed cancer, where we know delays to treatment can affect the outcomes for those patients. And we view that cohort as a key priority, and I referred earlier to our desire to not just maintain but improve our cancer waiting time standards. We also, as a board, are very clear, as Richard has said, that supporting and improving the well-being of our colleagues is key, particularly given the huge effort that they have given in the last 6 or 9 months, and indeed given what we know will be some challenging months ahead. And again, as Richard alluded to, we must do that in a borough where there are significant health inequalities, there are significant levels of deprivation, and actually as a large employer and a provider of healthcare services, we've got a duty to seek to address those inequalities at every opportunity. So those are the priorities that are guiding us now and will continue to guide us through the restoration and recovery period.
Thank you very much for that, Ned. We now have time for questions and answers, which I understand Jenna is going to be hosting. Is that still the case?
Yeah, sorry, Danielle.
Okay, over to you then, Jenna.
So we've had 4 questions come in around. So the first one is, can we update on spare capacity for the manor to perform routine operations?
I'd like Ned to take that one, please, Jenna.
Thanks, Richard. Thank you, Jenna. So in terms of routine surgical operations, we've gradually been increasing the number of elective operating theatres running on the Walsall Manor site. And we've also maintained access to elective operating on the Spire Little Aston site, which continued through that first surge of the pandemic and is continuing now. So our surgical team on the Manor site have indeed this week just reopened our 7th elective operating theatre, and we've gone from 1 to 7 on site since the 28th of May, when the first elective operating theatre reopened. That now means our elective operating sessions that are available for people needing surgery are at pre-COVID levels. So we've got no issue now with access to operating theatres. We do still have challenges, as other trusts do, with the need to be very cautious with our infection control protocols between patients on an operating theatre list, and to make sure our staff have got all the adequate personal protective equipment during an operating list. And that does mean that the number of patients that we can operate on in a day is slightly less than it was before COVID, but restored in terms of the availability of theatres now.
Thanks, Ned. The second question was an update on stroke rehab treatment. Now it's been moved, and what alterations have been completed.
Darren, could you take this one, please?
Yes, thank you. So obviously there's been some moves as a result of our COVID response. So the stroke rehab unit moved to Hollybank with the very grateful support of the local authority and also Walsall Housing Group in the first weekend of April. And we've continued to strengthen that service as a stroke rehab unit now, rather than it being an in-hospital facility. And we are now looking at what's the continuation of that pathway into the community, so that it becomes a community service that's embedded within the community as well. Finally, there's an oversight report that's due to go back to the Health Overview and Scrutiny Committee later on this year. That report has been delayed as a result of COVID and obviously changes in those committees, but we're due to report back, and I think we've scheduled it for December now.
Thank you. And the third question is, have staff been fully involved and engaged in operational changes?
So I'd like, I guess from a hospital perspective at least, Ned to take this one, because he's been leading the process of recovery planning, in particular with clinical leaders and general managers in the trust. Ned, are you happy to take this one?
Thanks, Richard. Yeah, so I think it's worth reflecting that during the most intense period of the first surge, we had a command and control structure where our decisions were being taken on operational changes. And the sheer speed with which the number of patients presenting with COVID was escalating meant many of those decisions needed to be taken very quickly. And the nature of that sort of decision-making structure does mean there isn't as much time for consultation and involvement as there would be in normal running. So we recognised that, but made sure that we had cross-representation from our colleagues, and indeed introduced our staff side reps as being members of Tactical Command as well, to be a voice of the wider organisation. Through restoration and recovery, those changes are much more akin to normal service development changes. Clearly, they're slightly less immediate in their time nature, and so have a greater ability to involve staff. But again, the sheer scale of changes that have taken place in recent months will inevitably mean sometimes it will feel difficult for colleagues to keep up to date with everything that's going on, and we recognise that, and mindful of that, and have learnt some lessons with some of the changes that we've made early on.
Thanks, Ned. And just a fourth question around the impact that COVID's had on the A&E A&E build.
Richard, do you want me to take that one?
Yes, thanks, Ned.
No problem. So COVID itself has not had a direct impact on our new emergency department build. I think a huge credit to the clinical teams that managed to continue design work, and of course to our estates teams and our partner Interserve for this hugely important development. So no, the pandemic itself hasn't directly affected the development.
Thanks, Ned. Those questions were put forward by Councillor Ian Robertson. So I'm just going to check in with him because I see there's another question coming through the chat box as well.
So, sorry, Richard here. I'm more than happy to take Councillor Robertson's question there in the chat box if that assists, and then we can pick up Anna's question above that as well, if that's all right, Jenna. Ian, your question is, what effects has the COVID pandemic had on the mental health status of the staff, and what care have we put in place for them, I think is the thrust of the question. The bottom line is that certainly during the months of March, April and May, when the first wave of acuity of presentations and work done in community services and the first wave of hospital-related admissions hit its peak, the impact that this had on our clinical staff and those supporting them was huge. And I don't know whether we will ever fully understand or appreciate the extent to which people were affected by this. It's had very much an emotional impact on people, because what we found, certainly at the peak of the COVID first wave, the rapid deterioration of patients with COVID was certainly quite distressing for those clinical staff looking after them. The impact on colleagues as well, who were asked and willingly went to work in other parts of the organisation, sometimes in areas that they had not worked in for many years or had never worked in before. That should not be underplayed, I think, in any way. And there was a physical impact on people as well, because we got through this, and we'll get through any future waves, through a huge amount of discretionary effort from a lot of people that will probably never be properly repaid. One can't repay that financially, because of the physical and emotional impact that has over the long term. We recognised this impact it was having on people very early, and along with best practice from other organisations locally and nationally, we put in place a series of interventions, some of which Danielle shared in her introductory remarks, including, for example, a safe haven area for staff who, by their own acknowledgement, were struggling during or after a particularly difficult shift, psychological support on a 24/7 basis that we procured ourselves, and then also worked with the local mental health trust on to ensure that staff who were particularly distressed or in difficulty as a result of what they were facing got the right psychological support from the appropriately qualified and empathetic people. And we've also put in place an investment in our occupational health service as well, which will be sustained for the long term, so that we can not just value our colleagues in terms of words, but actually value them in terms of the right support from our occupational health clinicians in greater number. There are many other things as well, Ian, that we could describe, but I think my final comment in regard to your question would be, we need to learn from the experience of that first wave, and the things that we did well as an employer and the things that we did less well and reacted too slowly with, such that colleagues helping us to manage the probable second wave, no matter how big that is, can do so knowing that their organisation, their employer, will support them, that we have their back, as it were, and that we'll make sure that within the limits of what we can physically do, we will put the support in place that they need, both physically and psychologically. So hopefully, Ian, that answers your question.
Yes, thank you.
Thank you. And then Anna's asked a question regarding how will we restore vehicles via which the organisation celebrates and shares good practice, whilst obviously staying within the whole COVID national guidance and social distancing and so on. Well, the answer is via a number of means, Anna. We continue with staff recognition awards and the recognition cards that I sign every month for colleagues who have demonstrated excellence in practice that their colleagues wish to, or indeed service users wish to nominate them for. We will be celebrating the Trust Awards this year for a range of best practice that our staff deliver, but doing it in a very different way. And going out and about to each award winner's department or service and celebrating their good practice and success with them as a senior team. We'll obviously continue with the Quality Improvement Awards, linked more explicitly now to our improvement programme. And so best practice by anybody in the delivery of our improvement programme objectives and ambitions will absolutely be rewarded. And of course, reward is one thing, but the sharing of good practice is another. And the improvement programme as the vehicle via which we will deliver our objectives and deliver our ambitions in the future should help us to disseminate best practice far more quickly. And we've appointed a new director colleague in Glenda who can assist with the dissemination of that best practice across the entire trust in the future. So hopefully, Anna, that's a high level, at least that answers your question. And I think that's it, Jenna.
Yeah, we haven't had any more on via email.
So thank you very much for that, everybody. I will just pause and give the opportunity to anybody that hasn't raised a question either via email or via the chat, whether you now wanted to ask a question. And that is for members of the public, colleagues, or indeed board members. Rajpal. Rajpal Verdi, you've got your hand up. Did you want to ask a question?
Yeah, sorry, I didn't realize if you could, but just to say a couple of questions, if I may. First of all, can I endorse all the things you said, Danielle, in the beginning?
Yes, I think you've got time for one question though, Raj.
Yeah, okay, one question then. Rich, well, it relates to Russell and finance. Russell, you indicated that we have 9.7 million we spend on clinical negligence. Now, just in terms of comparators, I mean, I don't know precisely what the figure involves, but in relation to other trusts and what mitigating factors we have in place, is it possible to share any further light on it?
Yeah, happy to answer that, Danielle. So the trust makes a contribution, as all trusts do, to the NHS Litigation Authority. And this is the amount of resource we pay over to the NHS Litigation Authority as a pooling of resource to then be able to settle claims that occur across the whole country. When we make the assessment and when our premium is assessed, we supply information based on numbers of doctors, numbers of specialties, and the premium is determined centrally, and then we are notified of what that premium is. So it's not individual claims, it's effectively our insurance payment.
Thank you very much for that, Russell, and thank you for your question, Rajpal. I'm
Thank
just
you.
going to check and see whether anybody else who hasn't had a chance had a question. Okay, so it doesn't look as though anybody does. What I would just like to say is that you've heard from the whole team about some of the achievements that we've reached over the year 2019-20, and also about the challenges that we've faced and how we've dealt with them during COVID-19. The whole board is very appreciative of the work that Richard and the team that he has built that they're actually doing on behalf of the people in Walsall. And we're very appreciative of the work of colleagues and volunteers and the support that we've received from the wider community and partners. So on behalf of the whole board, I would just like to say thank you to everybody that's being involved, and we will continue to work very hard on behalf of you all to make sure that Walsall is achieving excellence and outstanding by 2022. Thank you very much for your support.
Thanks, everybody.